So end of life choices, as we're kind of exploring and navigating this thing, everyone says, just take me out back or take me out back behind the woodshed or take me to the forest. Like, just exceedingly unrealistic. Everyone talks about this, the plan, and I have seen it kind of actually taking place or heard of it taking place where there's some sort of situation like that. Probably 3 times out of the probably 100,000 people that I've been around as a part of dying or helped navigate, or the people I talk to and in the circles I kind of work in, it just isn't really a plan. So you got to push past that initial wall and find out other things. The reality is lots of hospitalizations. Hospice can be an option. Death with dignity was a question that someone had. How does that work? Voluntary cessation of eating and drinking was another question. So kind of real quickly, we'll run through some of those. Hospice, again, the biggest takeaway is that hospice is a philosophy of care, and it's also an insurance benefit. So anytime you try and take a philosophy and turn it into black and white, you have lots of kind of conflict there. But ultimately, a big picture prognosis less than 6 months. And when you're ready to focus on quality over quantity, and you don't really want to go to the hospital to fix things, that's when it's probably right for you. It's a holistic, multidisciplinary approach to bringing the care to where the patient lives, whether that's home, facility, park bench, in their car, in the hospital, wherever they might be. And so a lot of nuances there. We could talk about hospice for days in terms of all the kind of components to it, but those are the big picture things. And we just ultimately say that the earlier you get them involved, the better the outcomes in terms of caregiver burnout, symptom management, perception of quality of care, pain management, all of these things. And so there's tons of benefits for hospice. Very rarely does anyone say, I did it too soon. Almost everyone says, I wish I had done it sooner. So just kind of keep that in mind. So VSET is a thing some of you may or may not have heard about before, but it's this concept that we all basically have the ability to choose if we want to eat and drink, and no one can take that away from us. We can't force people to eat and drink. The one exception might be in components of like anorexia, where there's like a clear mood disorder that's impacting those people. But ultimately, in a person with capacity without some sort of mood disorder, that's kind of a patient's decision to eat and drink. No one can kind of impact that. And so it's done with an intent to end their present or imminent kind of suffering that they might be having. This is legal in all 50 states. There's no component where it's illegal. It's a lot of there's definitely some ethical dilemmas kind of been built in here for sure, but through talking about it in conversations with your healthcare provider, if that's something you're interested in or your loved ones expressing interest, you can always kind of talk about it. What it's not is, it's not suicide, it's not euthanasia, it's not physician suicide. It's ultimately the distinct thing from starvation or disease or neglect or anything like that. It's kind of the person actually driving that. There's a fantastic resource, a whole packet with just a ton of things that kind of you can think about, and elements, kind of contracts through this End of Life Washington, and they have this whole packet. And basically everyone has, again, kind of the ethical components of this. We have the right of bodily autonomy. It's equivalent to refusing any other medical treatment in terms of a feeding tube or CPR, any of those things. And there's a lot of ethical frameworks that say it's okay if you want to make that decision. You have the capacity kind of to do so. There's no one forcing you to be here or to live a particular way. So kind of just an interesting way out, if that's what you're looking for. Death with dignity, certainly a sort of a parallel here. Ultimately, when kind of identifying, there's in Idaho, we have a lot of states that we basically are surrounded, that it's legal. When we look at the population of the country, only 26% of people have access to this. There's a lot of kind of rules and residency components that used to exist that are now different. You no longer have to be a resident, for example, in Oregon to get access to this. In some instances, you don't have to request 2 weeks apart any longer. There's kind of lots of things that make this accessible now to Idahoans, and it'd be really important for kind of all of us to be familiar. You do need to have obviously kind of multiple clinician contacts. And so, continuing on the kind of the medical component again of what death with dignity is, you basically have to be able to get yourself to Oregon. You have to have kind of the resources or insurance to kind of access these things. But ultimately, if you have a terminal prognosis, you have 6 months or less to live, and you don't want to just sit around and suffer for that remaining time that you have left, you ultimately can, choose to kind of undergo this. Again, assuming you have capacity, it's not considered suicide or euthanasia. Certainly, lots of legal considerations. For example, life insurance cannot deny you benefits. If your doctor doesn't want to do it or doesn't believe in it, they are allowed to object, but obviously have to refer you to get that access to that care. And again, the ethical considerations, autonomy, beneficence, non-malfeasance, and justice, and kind of all of those things. Again, ethical parallels of, terminal extubation. Is that euthanasia? Palliative sedation, is that euthanasia? Deactivating pacemakers, stopping nutrition and hydration in someone who doesn't have quality of life, or there's a lot of things that are really similar to these ideas, that we use in common kind of framework. And so it's definitely something that many people kind of believe is a really important right. And so